Thanks, Chiming. Yeah, so this title, you'll see sort of where the inspiration for these rounds sort of came about. So the inspiration was actually this article that was published at the end of 2023 in JACE, the Journal of the American Society of Echocardiography, which it's actually quite a nice read if you have time to look at it. It's a little bit it's quite echo niche. So for echo nerds, it's quite interesting. So it's called the Echocardiographic Patterns of Abnormal Septal Motion, and they refer to that as ASM, beyond myocardial ischemia. It's by a combined group from Italy and from Wisconsin. And as Dr. Chow mentioned, this is also a kind of homage to a couple of rounds I presented shortly after I came on staff called Funky Flow, which I'm going to represent sometime later on this year, just as a variant of funky motion. So we're going to review some basic principles of wall motion interpretation. I want to highlight a less common variant. And then the meat of the talk is really some aspects of that particular JACE paper on abnormal septal motion, or ASM, with illustrative cases, and I have a few kind of interesting cases at the end. So kind of, folks can put their thinking caps on, a few outside the box cases. So just as a reminder, in terms of, what determines wall motion in the setting of coronary disease, is something that's a core part of echocardiography. And when we talk about wall motion, we really don't, we use the term wall motion, but we really refer to wall thickening. So it's that thickening of the myocardium during contraction in systole. And this graph just shows the relationship between blood flow on the x-axis and percent systolic thickening as a measure of contractility or wall motion. And as many of you know, as you reduce blood flow in the setting of acute ischemia, you get systolic dysfunction to the point of no systolic thickening. So that's akinesis, and this, of course, is the basis for stress echocardiography, where we try and induce ischemia and then see the resultant left ventricular systolic dysfunction. You can also have wall motion abnormalities in the presence of infarction, so myocardial infarction, myocardial necrosis. And this slide here and graph just reminds us that an akinetic LV segment does not necessarily mean transmural myocardial infarction. So you can see actually an infarct thickness of just 21 to 40%, so a subendocardial infarct can result in zero systolic thickening or even systolic thinning, which is dyskinesis. So you could have an akinetic myocardial segment in the presence of a non-transmural infarction. And the last kind of core principle to remember about wall motion or wall thickening is that when you look at anatomically the left ventricular myocardium, you can divide it up into essentially three layers: the epicardium, the mid-myocardium, and the subendocardium. And actually, this is just a nice study. This was an animal study where they placed sutures at different levels within the myocardium and then tracked their motion during thickening. And the majority of thickening occurs in the subendocardium. That's this line here shown at the bottom here, where a greater percentage of the wall thickening occurs in the subendocardium versus the epicardium. And that kind of also plays into why you can have a subendocardial infarct and have essentially an akinetic segment. So, even in the presence of subendocardial non-transmural ischemia, you can still have significant wall motion abnormalities, which is another advantage for us for stress echocardiography. Okay, so, while I say we should focus on wall thickening as opposed to wall motion, how we assess wall thickening is actually fairly qualitative. We actually don't measure wall thickness at end systole and end diastole and create a percentage. A few MRI studies have tried to define what normal wall thickening is, and I was able to find a few studies that suggested anywhere from 40 to 73% a little bit more on the lateral wall thickening versus the septum, for example. And having said that, like I said, we don't measure it, and it's more of a visual analysis whether or not we think the wall thickening is normal versus abnormal. And obviously, because of that, sometimes it makes it difficult for us to actually determine whether or not there's just mild hypokinesis. And in a setting where a lot of times we do visual assessment of systolic function, LV ejection fraction, sometimes we'll miss mild abnormalities. So you just have to be careful. So when you classify wall thickening, at the high end, you can have hyperkinetic or hyperdynamic segments that are hypercontractile. You know, somebody who's septic, for example, or has thyrotoxicosis. Somebody who's hypovolemic might have hyperdynamic systolic function, hyperkinetic segments. There's normal, and then when you get into the degrees of abnormality, there's hypokinetic, where wall thickening is reduced, akinetic, which is absent or negligible or very little wall thickening, dyskinetic or dyskinesis, systolic thinning or stretching of the myocardium, and then there's aneurysm. An aneurysm is a term that we tend to use only when there's focal dilatation and thinning, so evidence of remodeling of the left ventricle, and usually it's described as a shape deformation both in systole and diastole. And usually in aneurysm, the walls are either akinetic or dyskinetic. So to say that a segment is hypokinetic and is an aneurysm, it's two almost mutually exclusive terms. You can have hypokinesis, you can have a decreased wall thickening with dyskinesis, but it may not necessarily meet criteria for an aneurysm. So usually akinetic or dyskinetic. So here's normal. This is actually a cardio-oncology study. So it's one of the reasons why, despite your reasonably good endocardial definition in terms of tracing, we give contrast. So you can see nice contrast. And so this is normal contractility of all the walls here in the apical 4 on the top right, and the apical 2-chamber view on the bottom left. The bottom right. Okay. This is hypokinesis, and this is mild hypokinesis. This is mild global hypokinesis. EF here was 49%, 50%. You know, although as I said, in a busy lab, I think some might call this normal. Yeah, that's it. Might call this low normal, which is LVF of between 50 and 55% if you want to do it visually. But of course, with contrast here, you can see the borders wall. You can trace, and you get a good quantification of LVEF. And here's the apical 4 and apical 2-chamber view, severe hypokinesis to akinesis. And you know, I like the term severe hypo to akinesis. We use where you see a little bit of contractility, but it's almost negligible. Some might just call it akinetic. I think that's okay. So here in this segment, the 4-chamber here, what I would say is, you know, when you look at it, it's actually fairly global. You might argue that there's a little bit more contractility in the base to mid lateral wall, for example, but there's a little bit of contractility almost everywhere. So this is, you know, severe hypokinesis for me. On the right is the 2-chamber view, and here, you know, I probably would call this akinetic in the inferior wall, and then severely hypokinetic in the rest of the segment. So, but that's just me personally. So whether or not you call it severely hypokinetic versus akinetic, it's shades of gray a little. So here's a patient with a focal apical aneurysm. You can see on the 4-chamber view, this with contrast again to highlight the walls. You can see severely hypokinesis here of this apical segment in the 4-chamber view, but when you just focus on the 2-chamber view, actually you can see the bulging of the myocardium outwards. So this is dyskinesis. It's a pretty nice example of dyskinesis. The contrast really is a great way to illustrate apical dyskinesis. So here's a variant. It's a favorite of the lab. So it's a parasternal long axis on the left, parasternal short axis on the right. So this is one of Dr. Edwards' favorites, although I think Dr. Chow likes this particular variant as well. So what's this? So this is pseudo dyskinesis. So and it is dyskinesis because you know, when you look here, particularly, it's maybe less noticeable on the parasternal long axis, but more noticeable on the parasternal short axis. When you just focus here on the inferior and infralateral walls, you can see that during systole, when the walls are contracting, this segment looks like it's bulging downwards or outwards. But when you really focus on it, that wall is still thickening. So it's dyskinetic, but it's still thickening. And that's been termed pseudo-dyskinesis. And just illustrated here on the parietal long axis still frames, this is systolic, and this is diastolic. You see in diastole, the abnormality is actually in diastole as opposed to systole. When you look at it in real time, it almost looks like the abnormality is in systole, but the abnormality is really in diastole, where something is pushing on the infralateral wall of the left ventricle and pushing it upwards or inwards into the left ventricle, and then it becomes more rounded during systole, which is normal, but it creates this image here where it looks like the segment is dyskinetic. And there. So this has been described, actually first described in 1988. I'd have thought of it described earlier, but it's described in 1988 by De Cruz and Kleinman. And at least online, when I did a search, it's been referred to as the raising Haney sign, I think in part because of this paper that came later in 2002 on this paradoxical inferior posterior wall systolic expansion in patients with end-stage liver disease. But so it's this dyskinetic wall motion that occurs from the diaphragm underneath the left ventricle, compressing the LV, usually the inferior infralateral wall, and pushing it upwards, particularly in diastole, where pressures in the left ventricle are less, and that's due to increased abdominal pressures in disease states such as liver cirrhosis with ascites. We see patients with who have their abdomen full in the setting of peritoneal dialysis, for example, hepatomegaly. It really can be seen in any setting where there's external compression of the left ventricle, which is going to be always more marked during diastole, where pressures in the left ventricle are less, as compared to systole, where pressures rise during contraction. So it's that abnormal anterior or inward motion during diastole, followed by the abnormal posterior outward motion during systole. But as I said before, the abnormality is really during diastole, although when you look at it in real time, it looks like the abnormality is in systole. So the key is you have to distinguish it from any pathological wall motion. So you don't want to call a dyskinetic segment because it essentially infers an abnormality of the LV, usually underlying coronary disease. And you don't want to, and it's really a variance of normal. So it's important to not overcall it and to recognize that it's not pathologic, and recognize that actually the myocardium still thickens during systole and doesn't thin, or is not hypokinetic or akinetic as it would be in the setting of coronary disease and myocardial infarction. Which is, kind of goes back to what I said before. We talk about wall motion all the time, but we really focus on thickening. Okay, so over to septal motion. So this is just one of the figures from the paper, the J 2023 paper, looking at something called the eccentricity index, where they look at the dimensions of the LV in two orthogonal planes and do a ratio. And normally, if there's normal systolic contraction, it's the LV in short axis is circular both during diastole and during systole, and the ratio is essentially close to 1. So the eccentricity index of pretty close to 1. You can see normal septal configuration is a normal curvature of the septum that comes in during systole and then goes out during diastole. Okay, so echo rounds are meant to show echocardiographs, right? So let's show some illustrative cases. We'll get some input from you can answer online if you want, but we'll get some thoughts from people in the room. So parietal long axis on the left with an M mode on the right. Just take a look at that. Two views of the parietal short axis. At the base, mitral valve level on the left, more mid-pap muscle level on the right. Here's a couple of views, parasternal long axis, short axis, top right, and then some apical four-chamber view on the bottom left and a subcostal on the bottom right. RV inflow view with color Doppler showing the tricuspid vegetation, and then the Doppler profile here, CW, and the calculated RVSP is 100 millimeters. Okay, everyone's got their thoughts? Let's focus here and let's go here. Okay, so what do we see here? What do we think is going on? So first of all, what's the abnormal septal motion? Okay, so it's flattening in what part of the cardiac cycle?
Entire.
Yeah, it's both systole and diastole. Okay, and so the question is it pressure overload? Is it volume overload? Could it be both? Could it be just pressure overload? Do you think the driver is pressure overload? Well, there's a couple of clues to tell you the driver is pressure overload, right? So first of all, you have that RVSP of 100, right? And then the other thing is, what do you think about the RV? Yeah, there's extreme RV hypertrophy where the RV walls are actually thicker than the LV walls. That's very, very unusual. So, so this is RV pressure overloaded without volume overload. Now the RV is dilated, but there's no pathologic condition that causes volume overload in terms of what we classically think of. And one of the key messages here is that in the setting of RV pressure overload, it's actually quite common to see both septal flattening and systole and diastole. So this is RV pressure overload, and it's the leftward septal displacement. So the septum is displaced to the left towards the left ventricle. It's flattened, and it's progressive from end diastole, so still involves end diastole, to end systole, because RV diastolic pressures are probably still greater than LV diastolic pressures, especially in the setting of severe RV pressure overload. But it usually ends up being greater at end systole than at end diastole. And this is as a result of the prolonged RV ejection time. So in the setting of RV pressure overload, pulmonary hypertension, RV pressure overload, the RV ejection time increases, as well as the isovolumic relaxation time, and that leads to a reduced LV-RV pressure gradient, or the reverse is a higher RV-LV pressure gradient. And that leads to persistent septal flattening throughout the cardiac cycle. And a particular variant of this is where it's so severe, it's a reverse septal curvature. So it's not just flat or D-shaped. It's almost as if it's curved towards the LV, and it creates that reverse septal curvature. And that's been observed in pulmonary hypertension, and it's associated with a poor prognosis. And then in that setting, the eccentricity index is greater than 1 because the short axis height is reduced because of the septal flattening, and you get an eccentricity index of greater than 1. So going back to this case, so parasternal short axis. So what view is this? This is the RV outflow tract view, right? So, and what do we see here? Yeah, so you see systolic doming of the pulmonic valve, and you see flow acceleration through the pulmonic valve into the PA. And this is pulmonic stenosis. This is congenital pulmonic stenosis. And in this particular case, this is the reason for the RV pressure. So this is not pulmonary arterial hypertension. And here, this is the gradient across the pulmonic valve. So here, the peak gradient is 143 millimeters of mercury, and the mean gradient is 85. So this is like critical pulmonic stenosis. So this is just another reminder of where a high RVSP doesn't equate to pulmonary hypertension. Right? A high RVSP just tells you that there's RV pressure. So that's the caveat, right? RVSP, elevated RVSP is compatible with pulmonary hypertension in the absence of pulmonic stenosis. You got to remember that last part. So, and this is the tracing after pulmonic valvuloplasty. So it's now come down to a mean of 30, peak of 60. So still elevated, but kind of more in the moderate range. This is a before and after. It's a little subtle. So before is on top and after is on the right. Still septal flattening, but it's a little bit less. I don't know. I think it's a little bit less, but I think it's a little bit less. The RV is a little bit smaller as well. The LV is a little bit larger in comparison, but still septal flattening. Okay, case number 2. Parasol long axis on the left, M mode. Multiple views in the short axis from the base to the apex, going from top left, top right, bottom left, bottom right. So what's the diagnosis here? Sorry, guys? Yeah, so paradoxical septal motion or RV volume movement. And actually that's this also is nicely illustrated on the parasol long axis with them. Sorry. Yeah, so you can see, and why is this paradoxical septal motion? Because normal septal motion is outwards or upwards during diastole and in during systole. And here it's the opposite. So you can see in diastole it moves down and in systole it moves up. That's illustrated here on the M mode when you put the cursor in the mid portion of the LV. You can see systole is marked by the QRS complex. So at the onset of systole, you can see that there's inward contraction and motion of that infralateral or posterior wall. But at the same time, the septum moves almost in parallel with it. So when the infralateral wall is moving in, the septum is moving out. And when the infralateral wall is moving out during diastole, the septum is now coming down. It's almost moving in parallel. That's the paradox. It's the paradoxical septal motion, or RV volume movement. Okay, so here with RV volume overload, the dilated or enlarged right ventricle pushes the septum leftward or downward during diastole so that the septum appears to be flattened. And in systole, when the LV contracts, the septum becomes more of a normal circular shape, resulting in systolic anterior motion of the septum. So essentially, it's a D-shaped septum during diastole, but more rounded during systole. Okay, and the eccentricity index is also greater than 1, but it's greater than 1 at end diastole and becomes closer to 1 during systole. So why is there RV volume overload in this patient? So this slide kind of summarizes why there's RV volume overload in this patient. So what do we see here?
Shunt.
Sorry?
Shunt.
Oh, okay, so on the bottom, you can see a subcostal V, you can see a shunt, and shunt where? Left to right where? In the atrial septum, yes. So this is a secundum atrial septal defect. But on top of that, there's another reason for RV volume overload.
Torrential.
So there's severe / torrential tricuspid regurgitation because of RV dilatation, shown on the top. On the RV inflow view here, you can see the malcoaptation of the tricuspid leaflets and essentially wide open tricuspid regurgitation. So this is torrential tricuspid regurgitation. So here are 2 causes of RV volume overload. Usually we end up seeing just one. And at St. Michael's Hospital, the most common cause of RV volume overload that we see, what's the most common cause? Tricuspid regurgitation. Yes, exactly. Because we're a center of excellence for structural heart disease. So although it makes it more difficult to scan all these patients all the time, right? So severe TR. Okay, but here are 2 different causes. So I thought this was kind of neat. Trying to see outside the box a little bit. Oh, it's another thing. I think it should start. Okay, case number 3. This is easy for us because this is like bread and butter for us, right? So this is 2D ventricular independence. So ventricular independence is this shift of the septum downwards that occurs during inspiration but not during expiration. And the clue is that this is septal motion that does not occur with every single cardiac cycle. So if you see something that doesn't occur with every single cardiac cycle, but seems to be recurrent, then you have to think about, well, is it something that's related to inspiration or expiration or the respiratory cycle? And that's a clue. And that's something that the experienced sonographer, as you're scanning, will pick that up. And we see this, and when I give talks to discuss cases with the fellows, you can actually see this in some of our studies where the sonographer starts to study and they see this abnormal septal motion or some abnormal motion that doesn't occur with every single cardiac cycle. And then the key to that recognition, what's the key to that recognition? That they're thinking, oh, yeah, so you turn the respirometer on. So suddenly you start the study without the respirometer, and suddenly the respirometer turns on. It's like, and then a light bulb has gone off in the brain of the sonographer to say that, oh, this is interesting. And then to me, that whenever I see that and the fellow do that, I get this warm, fuzzy feeling. Because it's no, I really do. It's like, oh my God, this is like, you guys are great.
So it warms our hearts.
That is true. No, it's kind of it's taking scanning to the next level, right? So that's what we want to do. We want to have that excellence. So you can see here, this focus on my arrow, the septal motion goes down, but not every single cardiac cycle. And the same here with the apical forechain view. Every now and then you can see the septum go towards the left, the RV gets bigger, the LV gets smaller, and this is ventricular interdependence. And this is, you most commonly see this, well, most commonly see this after open heart surgery, but the pathological entity that we're most concerned about is constrictive pericarditis. And I'm not going to talk too much about this because for those who tuned in, I think it was in either November, probably, Basma Mohammed gave a fantastic rounds on constriction and talked about ventricular independence as one of the signs of constriction. So here, this is just a summary slide, and you can go back and take a look at this if you want to get a bit more detail. But it just essentially illustrates the pathophysiology of ventricular independence in the setting of constrictive pericarditis, where that pericardial constraints limits the total cardiac volume, so that when you have increased venous return on the right side during inspiration, the septum shifts to the left and causes the LV to be smaller. But during expiration, the opposite happens, and the septum shifts back to the right, and that creates that septal motion that's intermittent with inspiration, and that classic ventricular independence that we see with constrictive pericarditis. I mentioned that the place where we actually see ventricular independence most commonly, and it's not a sign of constrictive pericarditis, is post-op pericardiotomy, when the pericardium has been opened after bypass surgery or valve surgery. And so this is a patient post-op who essentially has ventricular independence. You can see every now and then the septum shifts downwards. You can see it much easier on M mode. The respirometer is not probably the best, but you can see here the septum has shifted from the right to the left. The RV becomes greater than the LV, and it happens during inspiration here, and here, but not with any of the other cardiac cycles. So this is M mode ventricular independence. This is in short axis here. Oops. Stop it. Yeah. So short axis here. And this is just late after surgery. So it's fully recovered, ventricular independence gone. And this is thought to be related to the inflammation within the pericardium that you get that causes essentially constrictive physiology in the absence of constrictive pericarditis. A lot of times these patients will have acute pericarditis, they'll have diffuse S-segment elevation. The surgeons will put them on coach C, etc. And sometimes they'll have a small pericardial effusion as well. Sometimes they'll have that boggy, inflamed pericardium that doesn't really stretch very well and creates constrictive physiology. So the other aspect of constrictive pericarditis is an abnormal septal motion, or ASM, that occurs with every single cardiac cycle. And that's the so-called septal bounce. And the septal bounce is a little inward or leftward motion of the septum that's high frequency that occurs with every single cardiac cycle near end diastole. And it creates that, and if you look here, you can see the septum is bouncing, or the other term that's commonly used for the septal shudder. And there's that little shudder of the septum. You can see that here. You able to see that? So that's another sign of constrictive pericarditis. Having said that, as a sign that I would lean towards for constrictive pericarditis is probably lower down on the scale. And I would focus more on ventricular independence. So the septal bounce. So that's the typical septal motion of constrictive pericarditis, described as a brisk, early diastolic movement of the septum, rapid anterior displacement followed by a rebound towards the LV posterior wall, and is related to the rapid filling in early diastole, causing a marked change in ventricular pressures. It's a fine fluttering movement. Okay. Case 4. Cardiac long and short, and then the apical 4, apical 3. So what septal motion is this? Yeah, so this is septal motion abnormality due to conduction delay, as we call it here. And actually, in the document, they've termed this the septal flash. First time I ever heard of the septal flash. It sounds kind of cool, actually. And I'm going to go too deep into the explanation, but essentially, in the setting of, and you can see this with the left bundle branch block, and you can also see with RV pacing, which essentially is essentially the same thing. Essentially, the right side gets depolarized before the left side. The left side is delayed, particularly the lateral wall is delayed. So in this setting, what you have is, and this is shown here in the longitudinal strain graph on the left, where red is the lateral wall and yellow is the septum. And don't forget, with strain, negative means negative is contractility. There's reduced strain. There's negative strain. So you can see here with timing, the septum actually has a negative strain or starts to contract in the pre-ejection period, and the lateral wall doesn't contract till late. And that's shown here, where you have early contraction of the septum, late contraction of the lateral wall. So early on, you get that septal motion, usually at the apex and septum, where it rocks, and it goes from left to right, and then in late systole, it goes from right to left. And actually, when you look at the septal motion with bundle branch block or with RV pacing, just look at the distal septum and apex. It'll rock right, then left, right, then left, right, then left. So that's termed septal flash. This is what I've termed this after the septal apical dyssynergy. That's my keyword, septal apical dyssynergy. So, although septal flash sounds kind of cool. So, and let's go back to the fourth chamber end. So now, here in that explanation, I'm just focusing here and here, and don't forget, this is opposite, right? This septum here, septum here. You can see that, right? It goes like this. Is that, can you see that? And on this side here, it's this way, this way. No? Am I dreaming? No?
This is cool because
I agree.
we've been looking at this for a long time and never really thought too much about the left to right and right to left motion.
Yes, this is the septal flash. It's cool. It's cool. For those echo nerds out there, it's cool.
How do you trace this?
Yeah. So this is where personally what I do is I try and at least for end diastole, I'll use the R wave as a measure of where diastole exists, and then within the R wave try and find a frame where the LV is at its largest or near largest. And then in systole, I go for the smallest chamber. And with the left bundle branch block, the smallest chamber could be very, very late. It could be somewhere in the middle. It all depends on where the contractile is. But I focus on the smallest chamber. And because sometimes if you focus on that frame just before the opening of the mitral valve, it'll actually be larger than earlier, and then you get an EF that's even lower. So, but and the other reason, message behind that is that when you have these abnormal motions, whether it's the septum, pseudodyskinesis, other cause of abnormal septal motion, our usual visual assessment of LVEF kind of gets thrown off. I think we're much better at looking at normal versus akinetic versus hypokinetic and putting it all together to come up with an ejection fraction range. But when you add the outliers, like abnormal septal motion, apical septal dyssynergy, septal flash, pseudodyskinesis, dyskinetic segments, or hyperkinetic segments, it becomes more difficult to do the visual assessment. And because of that, it's probably more important to try and do a full LVEF quantification with Simpson's likely. Okay. Yeah, so septal flash, septal apical dyssynergy. Very cool. All right. And just as another variant, is where the RV wire is placed, whether it's at the RV apex, at the septum, etc., changes the timing of depolarization and might change the septal motion. So septal motion and RV pacing isn't the same for all RV pacing. It probably depends on where that lead is. And now, as the fellows in residence know, we're actually looking at more novel places to place the RV pacing lead to create more physiologic pacing and prevent longer-term complications. His pacing, for example, septal pacing, etc., etc. Okay, case 5. So this is an ASM, abnormal septal motion. So it's actually best seen probably short axis. See that little drop here? And apical 4-chamber view. So what's the diagnosis here? So what's the cause of this abnormal septal motion?
So there's rheumatic events.
Yeah, so this is abnormal septal motion in the setting of severe rheumatic mitral stenosis. So in this setting, you have an early diastolic leftward or downward motion of the septum, and that's due to abnormal early diastolic transseptal pressure gradient because of delayed filling of the LV in diastole. So in the setting of rheumatic mitral stenosis, the LV fills late, and it takes longer to fill. And early in diastole, RV diastolic pressures exceed LV diastolic pressures, and you have that septal shift from the right to the left. Remember, the shift is always related to pressure gradients. So you have that early diastolic septal shift that corrects during later in diastole when the LVs had a chance to fill through the rheumatic mitral stenosis. Does that make sense? So it almost looks like an RV volume overload pattern. We have diastolic septal flattening, but it corrects in late diastole. So let's look at that again. You see that? And actually, you can tell early diastole just by opening of the orifice of the mitral valve here. So you can see how it drops in early diastole, but in late diastole it becomes more rounded. So that's a septal shift related to mitral stenosis. Okay. So here's a nice summary table from the paper looking at causes of ASMs, abnormal septal motion. So there's septal flattening, which could be pressure overload. So pulmonary hypertension, the setting of COPD, pulmonary embolism, a severe LV dysfunction, RV outflow tract obstruction, or pulmonic stenosis, as we've absolutely seen with that nice illustrated case. And that's that D-shaped septal flattening predominantly in systole, but you can also have in diastole as well. And then RV volume overload, commonly left to right shunts, such as ASDs, anomalous pulmonary venous drainage, and then tricuspid or pulmonic regurgitation as well. Septal bounce, which is every single cardiac cycle with constrictive pericarditis. Ventricular interdependence and constrictive pericarditis, occasionally seen in cardiac tamponade, seen in post-op settings with pericardial inflammation. The septal flash with left bundle RV pacing. The two I didn't talk about, theoretically, you can see abnormal septal motion with Wolff-Parkinson-White and right accessory pathways. I'm not sure if I've really convincingly seen that, like that. But theoretically, it is possible, just with regards to differential activation of parts of the left ventricle because of an accessory pathway, and then post-op septal motion. That is an anterior motion of the septum during systole with preserved thickening that resolves late. Multiple different mechanisms felt to be related to that, but I'm not going to discuss these. Okay. All right. So I want to finish up, I think, with two cases to kind of integrate things a little bit. Okay. Parasternal long axis with M mode. Look at that. So let's kind of we'll kind of go through it. Yeah. So what do you see? What do you see? Ashwin, what do you see?
So yeah, the M mode during diastole, the septum moves inwards towards the LV, and then notice it just So that's the primary.
Yeah. Okay. So inward doing diastole. So what pattern is this? Yeah, so this is RV. This is the RV volume overload. Okay. Okay. All right. Good. And anything else you notice that kind of maybe informs the RV volume overload pattern? Not on the M, but on the parasternal axis.
Yeah, I mean the RV is dilated.
It is.
Really
yeah. Okay. So the RV is dilated and hypokinetic, right? Oh, okay. Okay. Short axis. Oh, that's Flora.
So
spread around a bit. I don't see Sean. Sean?
I'm here.
Okay. Well, that's Flora first. I'll touch on you later.
So in short axis, we see flattened septum in both systole and diastole, the D-shaped septum.
Would you say it's more during systole or more during diastole?
Or during diastole.
Yeah, okay, I agree. So it kind of fits more with RV volume overload, but you kind of wonder if there's a little bit of flattening during systole as well. And then once again, you see the RV dilatation. Sean, what do you see?
Oh, that's interesting. So there's it looks like there's abnormal septal motion, but it's not with every cardiac cycle.
That is true. and that's great, Sean. I'm glad you picked that up, because it's actually very difficult when there's only 2 cardiac cycles, right? So you got to pay close. It's easier when you have 6 or 7 cardiac cycles, but you see an abnormal septal motion that occurs with 1 cardiac cycle, but not, correct?
Yeah.
Yeah. So what do we call this?
Well, it's suspicious for ventricular interdependence.
Yeah. So this is suspicious for ventricular interdependence. Certainly, I think you have to put the respirometer on, etc. So you have ventricular interdependence, and on top of that, you have an RV volume overload pattern, which you see better on the parasternal long and short axis, and you have a dilated RV with RV hypokinesis. So what are some of the possibilities?
The RV is so dilated that it creates pericardial constraint.
Yeah, yes, okay. And that's so this is a combination of ASMs. So I think Flora has kind of captured it. So this is somebody with an acute massive pulmonary embolus. So you have RV pressure overload, systole and diastole, although I could argue it's a little bit more in diastole, but they definitely had that D-shaped septum that was present. But it's interesting where, I think the D shape was definitely a bit more in diastole, maybe RV diastolic pressures were elevated. You have RV dilatation, RV systolic dysfunction, and then you have ventricular independence because of the acute RV dilatation has exceeded the pericardial constraint and essentially creates a pseudo-constrictive physiology. So it's RV pressure overload with RV dilatation and ventricular independence.
It's not a typical final sign.
No. Yeah. So, yeah, I have mixed feelings about McConnell's sign. I think it's a flag, but I don't. It's not pathognomonic for. It doesn't. You don't see it in all RV infarcts, for example. So, although you could argue that maybe the RV apical contractions are a bit more preserved than the rest, but it's not hyperdynamic, etc. Okay, I think this is the last case. Okay, all right, back to Ashwin.
Similar in that there's RV dilatation.
Yep.
Yeah,
hypokinesis as well. Yep.
And there's septal. So that's probably more
during diastole, right?
More during diastole.
Yeah.
But it's still a little bit during.
Yeah, having said that, it definitely gets more rounded during systole. Okay. Laura.
So in the April 2 and 4, it's harder to create the side.
There's no tricks.
So there's the inferior wall is hypokinetic.
Yeah, it's severely hypokinetic.
Not what we're
Well, is it?
I wonder if the inferior septum is also hypokinetic.
Yeah, okay, all right. So the inferior wall, inferior septal abnormality. Okay. And here is just more views, parts from the long axis, short axis, see the RV, the focused RV apical view. Kind of wonder, this is McConnell's sign, right? But this is not pulmonary embolism. Yes, yeah. All right. All right, same case. What do we see here, Sean?
So there's malcoaptation of the tricuspid leaflets. The RVSP is elevated. No, it's actually not. It's interesting. RVSP is only 16.
Greater than 16, so depending on.
Yeah.
But the tricuspid valve itself is not normal. It's thickened.
And the severity of the TR?
The severity of here, there is a PISA. I'm gonna say at least moderate, and need to see in other views.
Yeah, no, that Emily and Pega were commenting on the CW spectral profile of the TR jet.
Right.
Yeah, it's quite dense. It's a little bit triangular.
Yeah. So it's probably close to severe.
Yeah.
Okay. All right, and this is part of the PISA is probably because the RVSP is not high. It's low pressure tricuspid regurgitation. So what's the diagnosis here? What do you think? Give me a outside the box diagnosis that puts this all together. So it kind of goes back to this. So the short axis is the clue, right? So I think it's difficult to pick up the inferior wall motion anomaly, but you have an inferior wall motion anomaly, infroseptal. You have the abnormality of the inferior aspect of the RV that preserved the anterior aspect of the RV. So this is inferior MI with RV infarction, RV dilatation, and severe functional tricuspid regurgitation. So inferior MI, RV infarction, RV volume overload, dilatation, dysfunction, severe functional TI. That's the presenting ECG.
Well,
Well, yes, exactly. Okay, so here's a nice summary flow diagram. Actually, I like this diagram a lot. Actually, have you a chance to read it? It's pretty good. You have no time to do anything, right? Other than work and sleep. Okay, so abnormal septal motion, you identify it. Okay, next question is when? When does it occur? Is it only during inspiration? Then think constrictive pericarditis, maybe cardiac tamponade, maybe constrictive physiology. If it's every single cardiac cycle independent of respiration, when does it occur? Is it throughout systole? Then that's that post-op septal motion. Is it early systole, which could be left bundle branch block, pre-excitation, this septal flash, for example? Is it late systole in RV pressure overload? Is it late diastole with RV volume overload? And is it early diastole with every cardiac cycle that septal bounce? And then later on here is kind of the how, the explanation behind it, which we've kind of already been through. Okay. All right. And we're done. Okay.
Thank you. That deserves a big round of applause. It's a really enjoyable presentation. This funky series.
Yes.
No, exactly.
Any questions from the
More
audience?
of a thinking rounds as opposed to.
Very good.
Chi-Ming, it's Bob. Maybe just a comment.
Yep, go ahead.
So first of all, great rounds, Howard. Thank you. And I guess my only comment going back to my old time days is, and you made this point, but maybe to emphasize it, is the M mode really helps. And you showed a lot of M modes, but it makes it a lot easier to see what the septum's doing if you see it, at 1,000 frames per second sort of thing with M mode, rather than trying to figure it out on the 2D at way fewer frames. So just to make for the text and everybody, if the septum's not looking right, make sure you've got good M mode of the septum sort of below the mitral valve, so you're seeing the posterior wall well at the same time, so that you can compare systolic motion of the posterior wall with the function of the motion of the septum at the same time, and it does help, I think, really pinpoint what the septum's doing, and then you kind of go on to what the mechanism is.
Yeah, no, these are great points, but I agree with you completely.
So do you think AI can ultimately diagnose wall motion?
I think with good quality images, probably.
It's one of the golden grail.
The issue is good quality images.
As always.
So I have a quick question about left bundle branch block and EF quantification.
Yes.
Because the septal motion is delayed, when we do the Simpsons and we pick one frame, sometimes I find that it doesn't quite account for that extra squeeze that the septum generates later. And then the EF always looks a bit lower than what I think the overall EF is if this guy doesn't have a left bundle. Is there any adjustments we should be making, or just just use Simpsons for?
I think it all depends on the quality of the images. If the quality is good enough, and or you use ultra enhancing agents, I think a quantitative LVF I think is probably better. Trying to focus on as close as possible largest LV cavity versus smallest LV cavity, for example. But like I said, it's difficult because you don't have synchronous contraction of all the walls together. And the flip side is you have to be careful with your visual analysis because it's going to be thrown off in this setting. And then the last point I'll make is that we all know left bundle branch blocks are abnormal. So it's sometimes it's a setting of cardiomyopathy, whether it's ischemic or non-ischemic. So it could still be mildly reduced or slightly reduced, and that may be a reflection of an early cardiomyopathy, which you probably wouldn't want to miss anyways. But in that setting, in terms of assessing contractility, you're probably best doing something beyond LVF. So whether it's strain or myocardial tagging with MRI might be a better measure of systolic function per se as compared to ejection fraction.
Howard.
Yes, please.
Most of patients showing constrictive signs, do you still do the full constrictive assessment, or you just say post-op?
Yeah, I think we should document it. I think the most important thing is just make sure the IVC is not dilated. Having said that, a lot of patients after bypass surgery, after valve surgery, will be volume obliterated because they retain a lot of fluid. They're very edematous. So I think we're commonly doing the basic things anyways, like mitral and tricuspid inflows, partly because they always have a small pericardial effusion. So, I think adding on things for the constriction protocol is probably reasonable. We sort of do most of it anyways, like the tissue Dopplers, we do the IVC. The things that we don't do, I guess, are the longer loops and the M mode. So I think just showing that and just recognizing that you see the ventricular dependence is reasonable. A lot of times those findings resolve late after bypass surgery.
Question about when expected to.
Oh, hold on. That's a good question. I don't have an answer to that. Yeah, I have to admit I don't. I've taken the calling post-op septal motion out of my armamentarium. I don't comment on it usually on an echo report. It doesn't mean anything, and I think it's overcalled. But every single patient after, if it's Dr. Ladder, patient, inpatient, post-op septal motion. So I just to me it's used. So I said that.